Hi, I'm Dr. Rick Geyer from Texas Back Institute, and I'm with my two partners.
Hi, Dr. Jessica Shellock.
Hi, Scott Blumenthal.
And we're going to talk about updates and new advances in disc replacement from what we've seen over the last year. So I'm going to toss the first one out to Dr. Blumenthal. So what do you think about the new two-level disc replacement approval by the FDA and by the insurance companies?
I think it's a game changer. We're seeing more and more of the carriers start to jump on board. At least 50% of our patients have two-level disease. So patients that we weren't able to treat previously, we can treat now. So I think it's great for our patients is what it comes down to.
All right, now, Jessica, I'm going to ask you a question. This is something bugs all of us. So here we are. Now we have two-level approval for the lumbar disc replacement. And when we do our peer-to-peers and the peer reviewer says to you, well, lumbar disc is still experimental. What is your response?
Well, it's completely aggravating because we have 23 years of experience now with lumbar disc replacement. We have some of the best clinical data on lumbar total disc replacement. All the studies have proven safety and efficacy. They have proven that patients do as well and many times better than fusion patients. And the burden of proof, we've done it. So I think that they're standing behind a wall with just wanting to not cover this procedure. And the data is there. This should be covered.
Yes, and we had a great symposium yesterday, and hopefully everybody can access it, but there's over 800 articles produced on artificial disc replacement, and it's durable. Our personal revision rate at TBI is less than 1% after 22 years of over 2,000 patients. But we know that it works, and we know that it's durable. But now we have another situation with cervical disc. So we've been also doing cervical disc for greater than 20 years. And I'm going to throw this one back to Dr. Blumenthal. So as we get longer in our follow-up of cervical disc, not all are created equal. So what have we seen over the last year that is good and what's concerning at this point?
Well, in the past year, we've seen some next generation discs like the Pro Disc come out. We've seen more data on the totally MRI compatible Simplify. But I think the biggest buzz out there is potential complications, and kind of the word we're hearing more and more is osteolysis. And we do seem to see osteolysis more in what we call load sharing or elastomeric discs. It kind of first popped up in countries that have had longer follow-up than us, and then we did an internal study at TBI and kind of confirmed that. So I think that you're right. All discs are not created equally. And if you're going to be a cervical artificial disc surgeon, not only do you have to pick the correct prosthesis for your patient, you're going to have to learn how to revise. Although the number is a lot smaller than hips and knees, there will be revisions. And I think that's got to be part of your arsenal.
Yeah, and you're absolutely right. I mean, as we get longer and longer follow-up, we begin to see the blemishes of some of the artificial discs, much like we see with other joints. It's not a bad thing. It's going to happen. Nothing is made to last forever. But there are certain discs that seem to have better longevity than others. And in terms of multiple levels, Dr. Shellock, what have you seen in your practice in terms of, the number of patients that are candidates for 1, 2, and even more?
I think that more patients are candidates for multi-level than single level. The combination of C5-6, C6-7 disease, that is very prevalent. And, obviously in my practice, arthroplasty is the first choice if I, can. So I think that I've done more two-level disc replacements in the cervical spine in the last year than I've done, fusions, I think by far, actually. This point.
And what about the obstacles, even in our own practice? For example, on Friday mornings, we see lots of fusion, lots of problems. What do you think the main obstacle it is? Getting people to convert and understand that disc replacement in the lumbar spine is really, really good. Cervical spine, we know the results are great, and the results in lumbar spine are great, but how do you get that conversion?
Well, in terms of lumbar, and I think we heard it yesterday at our symposium, it's patient selection. And even the surgeons that were arguing for fusion said, oh, but they always say, but there are a small number of patients that are candidate for disc replacement. And what I keep wanting to say is, well, those are the patients that we see. We don't do disc replacements on everybody with a black disc. These are well-selected patients that have failed months, if not years, of non-operative treatment, and go through all the little funnels that we do, so that if you start with 100, you only end up with 1 or 2 that you're really indicating for surgery. And the fusion doctors agree with that. They said that in the symposium.
Yeah, and I think that's a misconception out there. Many people think that it's any person with back pain is a candidate for artificial disc, but it's really a very, very selective population that we sift through, as you said, to get down to those ideal patients.
Well, and frankly, personally, I think that for an axial back pain patient with purely discogenic pain, I think you're doing a patient a disservice by doing a fusion, because you know the failure rate's going to be 3, 4x, and starts out at 1 level, 2 levels, 6 levels, and then you get the whole deformity operation.
And now that we know that we have a longevity, what is your threshold in doing them in younger patients? In other words, the typical young patient that we'll see, they'll say, in high school, I hurt my back and I've had problems, and they just told me to go to the chiropractor, go to therapy. And then we see them, they may have had 1 or 2 discectomies done. They may have just a very, very degenerative disc, and now they're in their late 20s or early 30s. So how do you feel about that now compared to when we first started doing the artificial disc?
I think that for those younger patients, I'm personally, and I think you guys are too, I'm more vigilant in their workup, just making sure that they have checked off everything possible from a conservative standpoint, because let's be honest, nobody wants to have a surgery at all, especially in your late 20s or early 30s. However, if they've met all the criteria and they have failed all the conservative care and they're a candidate for disc replacement, I feel good about offering that to them. I would feel horrible about offering them a fusion. And in fact, I would tell them just to not have surgery and live with it for as long as they could if they weren't on a plan that was covered for a TDR. But I think that we've proven the longevity and the safety, and that, these are often life-changing operations for patients to really regain their quality of life. And I think that, quality of life is important at any age, but when you're in your 20s and 30s, that's when you should really be living your best life, and you want to be as active as you can. And I think that this is a procedure that allows for that to take place.
Yeah, and I think that's changed. The original FDA criteria were patients between 18 and 60, and most of the patients in the studies were around 40. And I think now that we have a longevity, because when we first started doing it, we told patients if they last 10 years, and we have to do something else, that's a pretty good result. But now we're seeing, and we come up on 24 years this March when you did the first one, that's 24 years, and we're not seeing any wearing out or any degrading or any failure of these implants. We haven't gone as far as some of our colleagues elsewhere that have told patients that, I'm going to put it in, it's going to last forever. We don't know that it's going to last forever, but we do know they're going to last for 24 years.
Certainly the revision rate is a lot less now, 2-3 decades into it, than we thought it was going to be. So it's been a pleasant surprise.
So what do you think's out there on the horizon? So people say, okay, now that we mastered artificial disc, where do we go from here? And the thing that bothers me, I realize that we have 2 really good artificial discs, the Pro Disc and the Active L, and I know there may be some others in the pipeline, but what do you think for the future? Do you think we're at the end of the maximal result we can get from an artificial disc, or do you think there's going to be further improvements in the actual implant?
I think that the implants we have are probably going to still be the players moving forward, at least here in the US. I think it's going to be difficult to bring something else in and put it through a clinical trial. And, it's expense, it's time, but I think that where we stand to gain further ground is perhaps in some of the expanded indications. And still, of course, there's plenty of ground to be made with coverage, especially for 2-level. So I think that, in my eyes, the next 5 years hopefully will bring more improvements in that regard. We may not see a totally new disc, but hopefully we'll see, more widespread adoption and coverage.
Well, that's a good point. Expanded indications. So how we changed since we first started doing these?
Well, in cervical, for sure, we've expanded to much older patient population. And patients in their 60s and 70s are just as good at candidates as the ones in their 40s, which was kind of the peak age in the study. I think in terms of lumbar, where we're still kind of in the 80 to 90% success range, I think we can expand the indications, but we're going to have to utilize big data and artificial intelligence to be able to predict and to prove to the payers, yeah, this is an expanded indication, but we've got data based on real world experience to say we can not only get 90% good results, now we're up to 97, 98 based on artificial intelligence and enhanced indication criteria.
So you make the interesting point that the elderly with multiple level cervical disc replacement do really well. And that's an area that we thought we would never do them in, and they have to do fantastic.
I mean, again, these are happy unintended consequences of experience, and I'm glad it turned out that way because I think we've done a good thing for those patients.
And what about adjacent to, say somebody has a fusion, Jess, and they're a candidate for one or two artificial discs. Now we know what the FDA says and whatever, but what do you think about those patients? Are we obligated to do another fusion on top of it? I know what the answer is, but I want to hear you articulate it.
No, absolutely not. I think that the idea of a hybrid construct is something that we've clearly adopted in our practices, and we feel confident that that's a better option than a 2-level fusion. I think that there's obviously patient factors and potentially access issues depending on what we're looking at as far as levels in the lumbar spine, let's say. But I think that again, whenever possible, if patients fit the criteria, I don't think a prior surgery, including a fusion, should affect that. We've looked at our own data and found that did not matter. The clinical outcome scores were still significantly improved, whether the patients had had a prior surgery or not. And we did look at patients that had had prior fusions. So, we can say that the patients still do well.
Okay, so we've done fusions forever and ever in the neck, and they've been considered to be the gold standard. And so do you think the cervical artificial disc has now risen to the new gold standard for the typical degenerative patient? I'm not talking OPLL, severe spinal stenosis, in those conditions.
Short answer, yes. The data is incontrovertible.
I agree. I think that it is the gold standard. And I think that in approaching patients who are surgical candidates, the strategy should be trying to determine why they wouldn't be a candidate for a disc replacement.
And I think that's a key point. When patients come to see us, we always tell them we look for reasons why we cannot do an artificial disc, not why we can do a fusion.
Exactly.
Because we want to preserve motion. And we've done that in all parts of the human body, whether it's the joints or artificial heart valves, even implants in your mouth instead of pulling your teeth. So it's just a natural evolution, and it's been, I think, one of the most gratifying things that we have done in our practice, that we've all migrated to now just doing arthroplasty for our own personal practices. But I'm so frustrated in our group that we haven't changed the mindset, and also outside of our group, of surgeons understanding and believing that motion preservation really is better, and it's a natural thing to do. So why do you think that is?
We talked about these in our symposium as well. And I think that in particular with lumbar disc replacement, because I feel that cervical disc replacement has become much more adopted. I think that there's a number of factors. I mean, I will throw out there that in some situations, there may not be a good access surgeon. So that's clearly going to make a disc replacement in the lumbar spine impossible. But I think that we still have substantial issues with reimbursement. It is not economically equivalent for surgeons to perform a disc replacement with an alternative option of fusion. And, it's often more difficult to get authorization for a lumbar disc replacement. Many times we have to deal with third-party pre-auth firms that require us to do peer-to-peers or external appeals. And we are then in a position where we're being asked to spend our time and effort to argue on behalf of a patient for a procedure that we get paid less to do than the alternative. And I think that very frankly, that is a reason why it is not as widespread of an option that has been adopted amongst surgeons.
So Scott, how do you think we can change it?
I think patient demand has changed with cervical for sure. I think that's forced a lot of surgeons who are holding on to fusions for, like you said, economic reasons, to have to offer disc replacement. Lumbar, it's just a bit more challenging for all the things Jessica said, but I think it's going to be patient demand.
Yeah, I think you're right. I think unfortunately, it all dates back to, I guess it was around 2007 when the FDA gave a non-coverage decision for the lumbar artificial disc. And by doing that, then the reimbursement through the antiquated RUC system and RVU evaluation has really killed it, because to do an artificial disc, whether in your cervical or your lumbar spine, is much more tedious and much more detail oriented compared to doing a fusion where you have lots of freedom to have a misplaced implant. Whereas in the artificial disc, we have to rebalance those soft tissues. We have to make sure we do a complete decompression on both sides in the cervical disc. And in the lumbar spine, we want to get that spot on exactly where it needs to be.
It's just not as forgiving, so it's
yes,
technically
it's not
more challenging. Exactly.
So what do we tell our patients?
Well, I mean, we obviously believe in this technology, and, we give our patients the data that, we have seen over 23 years to back and support this as an excellent option. Again, fortunately, in the situation that we're in, many patients are coming to us to get an opinion about arthroplasty because they know of our experience with it. And so, we try to tell other patients, if you've been told you're a candidate for a fusion, seek somebody out. See if you're a candidate for an alternative, because many patients are candidates for arthroplasty and have never been offered that by their other opinions.
And how do you deal with the patient that comes to you, Scott? And this happened to me the other day. Ideal candidate, had a couple discectomies, has a severe degenerative disc, but says that he talked to other doctors that told him that once you start having an operation with an artificial disc, it's going to be one thing after another, after another, after another, and you'll be sorry you had it done, and there's severe complications. And we hear this all the time.
Yeah, I mean, I think the best line I've heard is, your doctor's entitled to his own opinion, but he's not entitled to his own truth. And the fact of the matter is, the reoperation rate with fusion is much higher than disc replacement. Every study shows that.
Okay, any closing comments?
No, I think that we're just still in the good fight of trying to increase reimbursements, increase coverage, because this is something that I know that all of us sitting here really believe in and want this to continue to be an option to provide to our patients.
Enough said.
Okay,
Well
I
said.
mean, it's just, and I think the closing comment is the same as if you had a bad hip and you went to a hip surgeon and they said you needed a fusion, you would walk straight out that door to the total hip surgeon. And that's what we're just asking patients to give themselves a chance to determine whether or not they are a candidate for disc replacement, because it is a wonderful operation if you're a candidate. So thank you both. And
Thank you.
This is great.
Always fun.